again. It's Dr. Max Cohen. Today we're going to be talking about the examination of the heart and lungs. We'll start with the cardiac exam, which begins with a review of the vital signs to include particularly the blood pressure and the heart rate, assessing for hypo or hypertension, assessing for tachycardia or bradycardia, and then also assessing the rhythm to see if it's regular or irregular, to identify potential arrhythmia. And then we typically move to auscultation of the heart, which we'll be discussing a lot more and having a chance to practice in class. But essentially, as you may know, the heart has two atria, a left and a right atria, and then two ventricles, a left and a right ventricle. And when we're auscultating, we use these points, predominantly the aortic, pulmonic, tricuspid, and mitral blue circles, moving typically from that second intercostal space on the right sternal border to the second intercostal space on the left sternal border, moving down to the fifth intercostal space along the left sternal border, and then moving more sort of inferior to the nipple line along the fifth intercostal space in that mid-clavicular line, and that would get you the mitral point. And auscultating in these different areas is going to help to try to isolate important sounds that are often heard best at different areas. Sometimes folks will use mnemonics to remember this. Some people use all physicians take money, whatever works for you. The important sounds that you want to be listening for are the typical lub-dub, and that is an S1 and an S2. S1 is the sound that corresponds to the mitral and tricuspid valves closing, while S2 is created by the turbulent flow of the aortic and pulmonic valves closing, and we can hear this as the lub-dub, lub-dub. Then you want to also pay attention for any additional sounds, which in particular we care about the S3 and the S4. S3 can come immediately after S2 and is largely associated with rapid filling of the ventricle or sort of a volume overloaded state. And these tend to be low pitch, and people will often use the term Kentucky to try to remember this. And I prefer I believe, and you can hear that in the cadence of I believe, I believe, I believe, and that closely ties that S3 heart sound to the S2 heart sound, whereas with the S4, which comes right before S1, it's associated with the atrial kick against a stiff ventricle. Also a low-pitched sound and associated with the word Tennessee or believe me, believe me, believe me. So that ties the S1 closely to the S4 sound. Here's some examples. So this is a normal S1 and S2, and now we have an S3 and an S4. And we'll practice much more with that, but sort of for an introduction. Then we're going to be assessing for murmurs. Murmurs are, again, turbulent flow associated with sometimes valvular disease or abnormalities with the septum of the heart. And when blood is flowing in that turbulent fashion, we can sometimes hear it as a murmur. We use a grading scale to try to describe the severity or how loud these sounds are, ranging from 1, which is really, we say, only heard by a very experienced cardiologist, whereas a 6 you can really see or hear even with the stethoscope sort of off the chest. And then we also try to describe these murmurs based on where we hear them the loudest, as far as what auscultation point on the chest, and the portion of the heart cycle that it is heard best. For example, a systolic murmur, which is during systole. And here's an example. So this is swish dub, swish dub, swish dub, swish dub, swish dub, and that's a holosystolic murmur, meaning it's all throughout systole. And then in the diastolic murmurs, this will be proceeding and so you're hearing the distinct S1 and that's associated with mitral stenosis, but there are several other reasons for a diastolic murmur that we'll discuss more in class. Now let's move over to the respiratory evaluation. Again, beginning with the vital signs, looking at the respiratory rate, but then also inspecting for the effort, the quality, the symmetry of the chest rise and the respiratory pattern, looking for any signs of injury like a fractured rib or a displaced clavicle, and then looking at the work of breathing. Are they using accessory muscles? Is it deep versus shallow? Is it an asymmetric or symmetric chest rise? And then moving to auscultation. And when you are auscultating the lungs, typical normal lung sounds are bronchial or vesicular, or we call bronchovesicular to be all-encompassing, with bronchial being heard more along the trachea in the midline, and then vesicular being heard more out towards the periphery of the lungs. And then there's some abnormal lung sounds, which I'll play some clips for, including crackles, which formerly known as rails, wheezing, stridor, and rhonchi, sort of the predominant lung sounds that we want to know a bit about. This is a diagram of how to think about what areas of the chest you are listening to with your stethoscope. You can see sort of the cutoffs for where the upper lobe, middle lobe, and lower lobe are starting and stopping. Just take note that the right lung, although it has a true middle lobe, the left lung has a lingular lobe. It's not really a true lobe, but generally speaking, this is the way to kind of picture this. And then in the diagrams in the center of the screen here, you can see where you might move your stethoscope when doing your typical lung exam. So typically at least 4 points on the anterior chest, in the upper lung, and then the lower lung. And then in the posterior fields, listening and moving down the back in what some folks call a Christmas tree pattern, just medial to the scapular border, listening and then moving from one side directly to the other symmetric contralateral side so that you can compare what that area sounds like from left to right or right to left, whichever side you're starting on, and then moving down the chest and listening again, moving from one side to the other, and then making sure that you get that point around the side of the chest or laterally to get a good listen to the middle lobe or that sort of more lateral portion of the lower lobe. And here's some examples. So bronchial breath sounds heard more towards the trachea. It's a very hollow sound and tend to be higher pitched. And then you have vesicular, tends to be lower pitched, heard more in the periphery. abnormal finding, which is going to be crackles. Some folks will describe this as a bubbling sound or a crumpling paper. It tends to be associated with fluid or rapid opening of collapsed alveoli, the air pockets for oxygen and carbon dioxide exchange, and can be associated with things like pneumonia, fluid in the lungs, COPD. You can hear that popping sound, low pitch. These are called coarse crackles. They're also fine crackles. And then moving to wheezing, which has a musical sort of tone to it, a whistle, associated with narrowing of the airways, potentially from mucus and sort of thickening of the muscular layers, inflammation that you might see in things like asthma or COPD that create an obstructive process. And then moving over to stridor, which is a high-pitched inspiratory, typically whistling sound associated with narrowing in the upper airway, which might be associated with processes like croup or epiglottitis or a foreign body in the upper airway, potentially anaphylaxis with edema of the upper airway. And then moving to bronchi, which is sort of this gurgling or rumbling sound associated with secretions in the larger airways, sometimes heard in COPD, cystic fibrosis, or pneumonias. And then we can move to some additional testing after our auscultation, which may or may not be necessary, but important to be familiar with in case you do need to use these techniques. One of the first is percussion, which is creating sort of a sound wave by tapping a finger onto the chest in the intercostal space. When you tap in an area that is full of air, it should sound more tympanic and higher pitched. But if you hear dullness instead, then you might think that there's either not well aerated lung tissue there, like in a pneumothorax, or there might be a consolidation or some kind of fluid on the outside of the lungs blocking, like a pleural effusion. You can try whispered pectoriloquy if you think that there might be some consolidation there. You're going to be listening on the chest while the patient is whispering, and typically whispered sound is very muffled, but if somebody has increased transmission of sound waves when they say, for example, the word 99, so they'll whisper 99, but if you hear it much louder and clearer in a certain area, that may suggest that there's a consolidation there. Then we have bronchophony, and when you listen again to the patient saying 99, you hear a louder, more clear sound than on the contralateral side. And then egophony, this is where you're going to have transformation of the sound that the patient's producing. So if the patient says E, you hear it in your stethoscope as ah. So it actually changes the sound that you hear, and again, may be related to fluid or mass or consolidation in that area of the lung. And then we have tactile fremitus. You use your hands, typically the medial aspect of the hands, to contact the chest. And then as the patient says 99, you may feel increased or decreased transmission from one side compared to the other. And that can, again, be associated with fluid mass consolidation in that area that is helping to increase the transmission of those sound waves. And we're going to have plenty of time to practice this, so don't feel like you need to be an expert, but at least you've heard some of these words. Please feel free to send me an email if you have any questions, and I look forward to working with you in class.